So we are going back to make voting. Would you like to continue in this presentation, or to go to the 61 case which we send in the list, we send in the Telegram group? Which one you would like? I will leave voting for 1 minute if which one you would like to show, this 61 case, or continue in this presentation. Okay, I have until now 2 against 1, continue 3 against 1. So Dr. Nirmin seems to be that much to be continued. Okay, so let's continue. Just to close this one. Okay. Share screen. Share screen, please. Yes, here, current slide. So we were talking about posterior vertebral scalloping, and they like it in the exam, and they like it in MCQ. Already they have like few questions in FR and about this. What could cause posterior scalloping? Yeah. So they have many causes. Yes, where is the chat? Where I put sorry, current case. Why the chat doesn't appear? I don't know. Okay, so they have differential diagnosis. Yeah, what called increased intraspinal pressure and urolactasia, and like many causes of that cause intraspinal. Sorry, you will find many congenital and syndromatic in the urolactasia, Marfan, Ehlers-Danlos, and yes, I can ask you, Dr. Mahmoud, to yeah, close the video, because yeah, I don't know how to make it. Can you? Okay, because it appears in our screen. Dr. Mahmoud Brain, Dr. Mahmoud, can you close the video, please? Okay. So this differential diagnosis, either something local like intraspinal tumor and so on, or urolactasia, something in the spinal canal, congenital skeletal disorder, many differential, yes. And for example, here, one of the top differential we mentioned it will be, yes, neurofibromatosis. When you find this idiopathic scoliosis, they light in the exam, then you find this scalloping. So with the history, sure that you will think about neurofibromatosis. Okay, perfect. Okay, let's go to another case. When you find, yeah, I am waiting just to, if you want to tell me where is the pathology. I can, I think I show you the pathology already, yes. Alt H. Yes. Can you see the pathology here? Yeah, it is in the right iliac spine, sorry, the right iliac bone here in the acetabular roof, above just the acetabular roof. I cannot see the chat. I don't know if there is something happened. Just I will check the Zoom if there is any. Yeah, the chat appear again. Okay, let's come back. Again, it doesn't appear. I don't know. Okay, happening. So maybe just a small screen. And, so yeah, subarticular geode. Yeah, current study from current slide. Okay. Sorry, I'm just I have some error. I don't know what to. Let's make share screen again. Maybe it can help. Stop share. Yeah, share screen again. The chat, it doesn't appear when I make share screen. It disappear. Then I cannot follow you from current. So this is the area. Yeah. Again, it doesn't appear. Did anyone figure out how to show the chat, or maybe I cannot follow the answers now with you, so maybe someone want to talk better, because let's try last time. Chat. Okay, doesn't appear, so I will make share screen maybe for just the. So I will close the chat, maybe it can help. And make share screen again, new share. And from current study, it doesn't appear. Okay, so maybe someone want to talk better, because I cannot see the chat now. I cannot see the answers with you. Maybe I don't know if it is a good idea to make Bismoid. Now I can see it. So maybe new share, click advanced and make just portion of the screen. Yeah, so just I will choose. So now everyone can see clearly, or it's difficult? Everyone can see the pathology, or is difficult? Okay. Okay. So we mentioned maybe Bismuth, but it's not. Yeah. So this is another.
Bodies.
Yeah, another example. Yeah. Tell me what. What do you think about? Someone say that maybe subarticular geode. Okay.
Bodies.
Broodis.
Differential.
One of the good things that you think about Broodis, what is Broodis? What is Broodis? What could be? Yeah, what could be? Is it inflammatory? Is it tumor? Or is it what?
Subacute osteomyelitis. Subacute.
So it is infection. Perfect. So it is one of the.
Non-parasite.
Yeah. Okay. So well-defined geographic lytic focus surrounded by sclerosis. It will have good differential. Yeah. With lytic appearance, but don't forget it because it's infection. So give you and this appearance, and as you see, it was this appearance. So Broad's abscess, one of the important differential to know, and as sequestrum, involucrum, and if it is sinus tract, you will search for this. Sure that you will go for the age group of children, and the causative organism is Staph aureus. So the important treatment and the important diagnosis. Okay. Is it okay this appearance, because I just take part of the screen because to see the chat? It's fine with you? Okay. So let's go further. What it could be this one? Yeah, perfect. So with this new bone formation, you are going with osteomyelitis and involucrum. And why he show us this appearance? Why he show us chest? Huh? Maybe it's not. What do you think? Go a bit back and see. This, sorry. Go back and see. Yeah. Okay. So what about this one? Do you think that it's related? Or maybe, yeah. When you find this central depression, yeah. So H-shaped vertebrae. So what do you like to see? With H-shaped vertebrae, you are going to mention differential. One of the top differential will be sickle cell disease, right? So you would like to see the abdomen, or maybe to see something like here in the femora or the humeri. So if you find the femora, what is this going here? H-shaped vertebrae, bilateral EVN, and don't forget salmonella infection. Yes, when it is bilateral and you have this appearance, you are going with sickle cell disease. Again, the hand, multiple areas, expansion, bone expansion. And so sickle cell, one of the giant titles in the MSK. No exam without sickle cell. Any exam you will go, you will find some sickle cell, okay? So they like it much. Again, this appearance, yeah. So when you find this EVN, yes, one of the differential will be steroids and so on, but when it's young patient, okay, so think about sickle cell. And again, the vertebrae shape, H-shaped vertebrae. So what is the differential if you find central H-shaped vertebrae? Perfect. Let's review together. Yeah, will be Gaucher and thalassemia. Because of the infarction, make snow capping, which is the appearance here. Yes, in the humeri. When it have cardiomegaly, then splenectomy happen, then it is typical appearance of sickle cell anemia, right? Sometimes they present you the X-ray abdomen and show you cholecystectomy when he's a bit adult, okay? And don't forget EVN. So when you find EVN in a child, okay, go and think about births, but it look like a births, yeah? But don't rush in births. Think about other differential, and one of them it will be sickle cell anemia, okay? What about this one? Yeah. Jumper's knee. What is jumper's knee? Yeah, what could be jumper's knee? When you find something going in the tendon. Which tendon? This one? Yeah. So this is the patellar tendon, and this is the quadriceps. Yes. And this is the patella. And related to the inferior pool of patella, and you find this ligament and you find this high segment, which is abnormal. And sometimes you have this reactive edema. So you are thinking about tendinitis. And one of the important, yeah, that if this patient have repetition trauma, like he's an athlete or something, this called jumper's knee, is good to know. And here something is also related, which called Senden-Larsen Johnson syndrome. Yeah, similar pathology, Sometimes we consider it more when it is young patient. Okay, just to know. Let's go more further. Yeah. What happened here? Perfect. There is a rupture of the tendon. That's why I show you the tendon here is normal, ready like, sorry, I mean that the ligament fiber already intact, but you have something like tendinosis or tendinopathy here. But here you find like rupture of the tendon. The patella is pulled up and the tendon fibers already is torn, right? So patellar tendon rupture. You agree with me? Perfect. And here, if you see, you will find that the quadriceps tendon here, what happened again, is ruptured. Okay. When you find this appearance and it's normal, yeah, let's go to the MRI picture. And yeah, in the X-ray, to be honest, you look for any calcification here, because maybe after you find the checklist, you'll find one of the important check soft tissue calcification is calcific tendinitis, right? We mentioned it before, but what is going here on? So this is sagittal coronal image. This is coronal images, selected coronal images. So it should be T2, right? Because of the high fluid signal here, right? So this is T2. So how you recognize anterior or posterior? I think with this appearance of the glenoid, you are going to be this anterior. So here you are going to fix or to check the supraspinatus tendon, right? So do you see that there is a fluid signal here? So this fluid signal shouldn't be there. You should be the tendon, the supraspinatus tendon here, which is the one of the rotator cuff. So supraspinatus tendon, when you have tear in it, you have high signal in T2, and sometimes, as we mentioned, any tendon can have tendinopathy, and we search for the X-ray in the calcific, any calcific density that could be some sort of calcific tendinitis. And you should recognize, is it full thickness or partial thickness tear? For example, this one is partial, is not complete tear. And you will search for the cause. One of the important cause to know that maybe the acromion shape can cause this. Like here with this hook appearance, then you find the cause. I think this one, we talk about it. So let's just review quickly. When you find multiple sclerotic lesions in the pelvis or any multiple bone islands, you are talking about osteoporosis. But one of the important titles that you mentioned that you want to exclude, it could be sclerotic metastasis. So you will check for any reason for sclerotic metastasis if this patient have primary. Then you will go further, that you will go the common sites of this osteoporosis. That one of the common sites that it can go in the pelvis, can include the tarsus, the carpus, which is not common for metastasis, right? So, and finally, the uptake on the bone scan. If take uptake in the bone scan, so it will be metastasis. If it doesn't go uptake, it will be, not metastasis, right? Because it's just bone island. So this is what is called osteoporosis. And for example, it can show you in the knee, and here's you can recognize it, that one of the areas here. Okay, so in the same case, this one, what is happening more? Yeah, let's check. Yeah, when you find this, you go to check the menisci, the appearance of menisci. One of the variant that is very important in the knee, that to find the, yes, what is called
Discoid meniscus.
the discoid meniscus. It like to be more in the lateral meniscus, yeah. And they say that if you find it in sequential three images, sagittal images, then you can think about it, okay? Maybe it comes to in the short questions, okay? And there is one of the important to know, if you find cyst beside meniscal fragment, then you think about tear with cyst, right? Let's have a look in this case. So what are your differential? Yeah. So let's describe something that is here is like sclerosis, yeah. And this sclerosis affecting mainly the femoral head. Do you agree? It doesn't seem like this. Maybe is not. Maybe is not in the bone. Maybe is not. Maybe outside. It seems to be a bit difficult to recognize it inside, but you see something projecting over. So maybe it's joint space. So you'll put differential, right? You will try to describe and you put your differential, but I think the bone here is affected. Yeah. So when the bone is affected and you find this appearance, you are going to put some differentials, include amyloid, gout, perfect, and hemophilia. Yes. And when you go to MRI, you will find this blooming artifact with hemosiderin deposition, and this is a T2 sequence. So this is pigmented velonodular synovitis, which have dark signal because of the hemosiderin, right? Perfect. So differential diagnosis include amyloid and gout and hemophilia arthropathy. Another shapes of pigmented in the X-ray and in the MRI is very aggressive and sometimes take enhancement. Always when you check the cervical, you will go and check the alignment. Yes. And maybe you can suspect something here, right? What else? Yes. The predental space here, there is something abnormal. Maybe. What else? Let's have a look in the CT. We have many fractures here. So this sometimes what's called burst fracture, which axial loading with follow from height. Sure, that is here unstable. Okay. And yeah. You should evaluate if there is any retrobulging fragments that can compressing. If it is in, for example, in the lumbar spine, go to the thecal sac and anything else. Important to comment in the cord, and if there is any neurological disorder happen after or injury, sorry. Okay. So here, yes, there is something here. Is it fracture? Yes, it's fracture. Why? Because you can see the alignment is impacted here, and there is sclerosis, and yeah. So which type of subcapital and go in the intertrochanteric area, right? So hip fractures, intracapsular, intertrochanteric, and subtrochanteric. Yes. Subcapital hip fracture, which have the highest risk of avascular necrosis. So what happened here? Yeah, when you found
Teratoma sign.
teratoma sign, perfect, is a spot diagnosis for scapho-unate dissociation. Yeah, sometimes you can see other fractures, but the most important to recognize that this space shouldn't be more than 2 millimeters, right? Teratoma sign. And when you talk about the carpal instability, sure that you should check this line, which is the relation between the radius and leonate, and what should be here? The capitate, right? So when you see this line is disrupted and you cannot see the capitate here, and as you see it go dorsally, so they like it to, yeah, to mention that beryllineate dislocation. And then check for the scaphoid, which it should be here. As you see that there is already fracture in the styloid process of the radius, and the scaphoid is entrapted and fractured also. So that's what's called transscaphoid.
Scaffold.
Yes, beryllineate, yeah. They like it in the MSK, yes. The relation between the three, radius, leonate, and capitate, is very important, should be aligned. Then you should check this arcs, 3 arcs, yeah. So the normal position that the leonate with the radius and capitate should be in the one line. When there is dorsal dislocation of the capitate, we are talking about beryllineate dislocation. And as you see, many fractures can be associated, right? So there is other fracture, there is other types of instability which are more severe, which is mid-carpal. Okay, maybe mute. Okay, so when there is mid-carpal instability, which the leonate is subluxated anterior and the capitate in the posterior, I will show you the diagram now to be more obvious. Okay, and finally, the most severe type, which is leonate, when the leonate itself, leonate bone, is dislocated, okay, completely displaced. Okay, so what is happening here? This is the normal alignment, and this is the beryllineate when the capitate go dorsally. So this is the dorsal aspect, go in this way. And this is the mid-carpal, which is moderate severity, and this is the most severe one, which is leonate. Okay. So, for example, here you can see the appearance of the leonate, which changed. Then you check the alignment. You will find that there is something here with the leonate which is displaced. So this is what is called leonate dislocation. So let's have a look in this one. Which one is this? Yes. Which one is this one? Perileonate, perfect. Nermine, perfect. And perileonate, yes. So which one is this one? Let's check the alignment. Yes, and leonate again is not in. Yes, so this one is mid-carpal. Yes, this is the mid-carpal dislocation, and the final form, which is the leonate in the volar aspect, and it's away from its place. And here again, so you are talking about leonate dislocation. Here you will find many questions after you recognize the pathology. Yeah, what it could be this one? Yes, scaphoid fracture. Then he will ask you about the complication of scaphoid fracture. Yes, the EVN. Then the MCQ will ask you the proximal bole is affected or the distal bole. You know that the arteries come here and it gives supply to the scaphoid. So the distal bole will be the more rich supply, and the proximal bole will be the least supply in the arteries. So this one is more vulnerable or more prone to be, yes, EVN, to have EVN. So the scaphoid fracture can have EVN or non-union or osteoarthritis. They like it now to say snack and slack and so on. Let's go more further, and after this carpal instability, go to another. What? You have this elbow. Yeah, when you find this appearance, you are going to check the D's, yeah, D's. Density, distension, effusion, yeah, and debris, any fragmentation in the bone, any disorganization and dislocation, and so on. So when there is disruption in the ligament, and you will check for the type of neuropathy, neuropathic arthropathy, right? Yes. So 5Ds, or maybe sometimes more, neuropathic joint or Charcot joint. The causes: diabetes, syphilis, steroids, spinal cord injury, spina bifida, searing, scleroderma. This is more difficult to show you the cause and so on. Okay. Again, neuropathic joint happen with the syrinx formation. Yes. And again, neuropathic joint, but here with less frank dislocation. Yes. And when you check the ankle in MRI and sagittal image, which this one is T2 based or T1 based? T2 or T1 base? Fat sat or not fat sat? Yeah. Steer image, okay, so T2 based, and you can see the T2 signal here, okay. high signal and the tendon again. So tendon rupture. So this is the Achilles tendon rupture. You should describe it. They have one on the MSK in the ADIR long case. You recognize and you mention, and important to tell about the gap, and is it partial or complete tear again? Yes. Sometimes they ask if it is spontaneous. Could be spontaneous or not? The answer will be yes, could be. So what it could cause this spontaneous tear in the Achilles? Then you will answer diabetes. Perfect. What else? Gout, rheumatoid, yes, hyperbara. They have many causes, but it can come spontaneous, yes. They like it in the exam. Need surgery determined, but it is more than 50% of fibers ruptured or not, okay? They have in the radiographics, the RSNA site, I think they have template how to comment in the Achilles tendon rupture with the points that you should mention as structural report. Okay. Achilles tendon partial tear. This is considered to be tear with this thickening, yes, and abnormal signal. And there is some edema changes surrounding this tendon. So again, another pathology in the Achilles tendon, which is called xanthoma. Achilles tendon xanthoma with high signal and thickening, with the dark signal and thickening of the Achilles tendon. Then you can think about Achilles tendon xanthoma, and it can come bilateral, right? Yes. Here, this one, everyone like it. And when you see it, you will mention, I think it's just 1 minute. I don't know if you want to take break and we can take one more, or you want to continue, or you are tired to continue. Yeah, this is one is meliostosis, which is dribbling candle wax. Yes, they like it as antimony case. Even in the practice, maybe you not see it as much. Yeah. Again, this appearance with the dribbling candle wax. Just to know that maybe some complication happen with this one, which is characterized by thickened cortical new bone formation and accumulation, as you see in this bone formation, which give you this candle appearance, dripping candle wax. Yeah. So this the character and this appearance. When you find this, you will go with the other differential, osteopathia striata, and our lovely osteoporosis and third meliostosis. So this is what's called sclerosing bone dysplasias. Okay, take 1 minute break, and yeah, we will continue if someone